Good afternoon, everyone. Good afternoon. Thank you all for being here and welcome to those of you in the audience here and to those who are viewing via webcast for PD&R's quarterly briefing. Today's topic is child well-being in healthy homes. And I don't think we're going to get any hands to move this event outside at all. But it also clearly highlights that, as a reminder, that temperature and thermal comfort is an issue that affects health, especially in the home. So for those of you that are viewing via live webcast, in particular, I want to encourage you to follow along on Twitter and tweet your questions using the hashtag PDR Update, or email your questions to PDR Quarterly Update. Again, that's PDR Quarterly Update at HUD.gov. And for those of you in the room, the hashtag, Twitter handles, and email addresses are printed on the back of your agenda. I am Matt Ammon. I'm the General Deputy Assistant Secretary for Policy Development and Research here at HUD, but my most important title is Dad. I have 3 wonderful kids. I don't know how many of you are part of the More Than 2 Club, but it is zone defense when it comes to 3 kids, and we are certainly outnumbered. But as usual, in starting these quarterly, we're going to kick off our quarterly meeting with the famous Kevin Kane. He is our Chief Market Analyst who will provide us with an update on the state of U.S. housing markets, and particularly sharing news from the first quarter of 2016. We will then return back to talk about, with our panel discussion, again, on child well-being and healthy homes. I'll turn it over to Mr. Kevin Kane now.
Good afternoon, everyone. Thank you, Matt, for that introduction. I kind of like that, the famous Kevin Kane. We can maybe put that on the front slide. Before I begin, just want to say a quick note here that none of my remarks came from Michelle Obama. So just want to clarify that for the record. As always, I'd like to thank Randall Goodnight and Wendy Ip, who put together all the maps that you'll see in my presentation this afternoon. Just a note about the maps. The color scheme of the maps is the same as before, where brown indicates worse off conditions or declines in a variable, and blue indicates better conditions or increases. First, we're going to look at the nation's economy. Then we'll look at the sales and rental markets around the country. This first figure shows the year-over-year percentage change in non-farm payroll since 2006, looking at both the 12-month and 3-month averages through March of 2016. Non-farm payrolls are a measure of the number of jobs in the economy. The 12-month average is shown in blue, and the 3-month average is shown in red. During the 12 months ending March 2016, non-farm payrolls averaged 143 million jobs. This was up 2%, or 2.8 million jobs. The rate of growth was unchanged from a year ago. The 3-month average through March was up by a slightly lower rate of 1.9%. Total job gains during the first quarter were led by the education and health services sector, which added 680,000 jobs. The professional and business service sector added 600,000 jobs, and both of these sectors were up by 3.1%. The construction subsector had the highest rate of job growth. This was up by 4.5%, or 270,000 jobs. Employment in the mining and logging subsector was down by more than 16% from a year ago, or 141,000 jobs, resulting from continued cutbacks in response to declining energy prices. For the 20th consecutive quarter, every region in the country added jobs relative to a year ago, and the entire country is in blue. The year-over-year rate for the nation during the first quarter was 1.9%. This compares with an increase of 2.2% a year ago. The map looks exactly the same as last quarter, the colors do. The three regions in darker blue grew at a faster rate than the national average, and you can see that's the western regions and the southeast. Growth was strongest in the Northwest at 3.1%, led by gains of 3.7% in Idaho and 3.4% in Oregon. Jobs in the Bend metropolitan area were up by 6.1%. And compared with a year ago, the rates of growth were the same as during the same quarter last year, with the exception two regions had notable declines, including the Southwest, where the rate declined from 2.6 to 1.1%, and the Rocky Mountain region, which declined from 2.9 to 1.7%. The national unemployment rate was 5.2% during the first quarter. This was down from 5.8% a year ago. The six regions in blue had a rate that was less than or equal to the national rate, led for the third consecutive quarter by the Rocky Mountains at 3.7%. The four regions in brown had a higher rate than the national average, led by the Northwest at 5.8%. And on a state level, unemployment rates ranged from a low of 3.1% in Hawaii, South Dakota, and New Hampshire, to a high of 7.5% in West Virginia. And on a national level, the unemployment rate was down by 0.6 percentage points from last year. The unemployment rate declined in every region of the country, once again all in blue, and the four regions in darker blue declined at a faster rate than the national average, led by the Pacific, which was down by 1.2 percentage points. Unemployment rates declined in 38 states, including the District of Columbia, led by New Jersey, which was down by 1.9 percentage points. Now let me give an overview of housing market conditions throughout the country. Sales market conditions remain relatively balanced throughout most of the country, with some areas of tightness. For a bit of background, balanced conditions exist when the quantity of housing supplied equals the quantity demanded. Soft markets occur when the quantity of housing supplied exceeds the quantity demanded, and we have a housing surplus. And tight markets occur when demand exceeds supply, and we have a housing shortage. All three home price indices show that home sales prices continued to increase during the first quarter, with the rates of gain remaining relatively stable compared with the previous quarter. Home sales increased by 7% during the 12 months ending March 2016. This compares with a rate of 5% increase last quarter. Inventories of new homes for sale were up by 19% from a year ago, and they were down by 3% for existing homes. And based on the current rate of home sales, there's a 5.5-month supply of new homes. This is up from a 5-month supply a year ago, and there's a 4.4-month supply of existing homes. This is down from a 4.6-month supply a year ago. The sales vacancy rate was 1.7% in the first quarter. This is down from 1.9% a year ago. All regions of the country have rental markets with tight or slightly tight conditions, except for the Southwest. 65% of apartments completed in the fourth quarter were absorbed in the first quarter. This compares with a rate of absorption of 59% a year ago. And multifamily production decreased by 2% in the first quarter, compared with a 15% increase that we saw last quarter. Let's take a look at regional conditions around the country. These are assessments that are provided by our field economists. Relative to last quarter, improvements in an area are shaded in blue, and declines in conditions are shaded in brown. Sales market conditions remain relatively balanced in many regions of the country, with tight conditions in the Rocky Mountains and the Northwest. Conditions have become more balanced in the New England region. On the rental side, nearly all regions except for the Southwest have markets that are experiencing tight or slightly tight conditions. Conditions have slightly tightened in New England, and previously tight conditions in the Great Plains have become more balanced. A little bit of softening has occurred in the Rocky Mountain and in the Pacific regions. This next figure shows the year-over-year change in home price indices, and this is looking at the three top home price indices. In March of 2016, the S&P index, shown in blue, and the CoreLogic index in black were both up by more than 5% from a year ago, and the FHFA index, shown in red, was up by 6% relative to a year ago. The rates of increase for the S&P and the FHFA index are nearly a percentage point from a rate, are up nearly a percentage point from a year ago, and the CoreLogic Index is up by the same rate as last year. In this next map, we see the change in the monthly CoreLogic Index on a state level from 1 year ago. And again, the national increase was 5%, which was down from an increase of 6% a year ago. Prices were up or unchanged in all states, including the District of Columbia, except for one lone state in brown, that's Vermont, where prices were down by 1%. Prices in the two lighter shades of blue increased by less than or equal to the national average, and one of those was unchanged, which was Connecticut. Prices in the two darker shades of blue were up by more than the national average, led by Washington at 11% and Oregon at 10%. And according to the Census Bureau, the median price of a new home in the first quarter was $289,600. This was down 2% from a year ago. And according to the National Association of Realtors, the median price of an existing home was $215,800. This was up 6% from a year ago. Let's take a closer look at the Southeast region. Prices were up in 79 metro areas in the Southeast. They were unchanged in 7, and all of those are shown in blue. And they declined in 5 areas, and those areas are shown in brown. Areas in the lightest shade of blue increased by less than the national average or remained unchanged. Areas in the two darker shades of blue increased by faster than the national average. The 6 areas in the darkest shade of blue had double-digit price gains, led by Sebring, Florida, at 15%. Coincidentally, Sebring also had the highest increase in jobs in the region in the first quarter. This next map shows the percent of home loans that are 90 or more days delinquent, in foreclosure, or in REO as of March 2016. REO stands for real estate owned, which means that the lender now owns the property. The national average was 3% of all loans in those 3 categories. This was down from 3.8% in March of 2015. We continue to see the same split across the country, with the regions in blue below the national average and those in brown above it. The map is unchanged from last quarter in terms of the colors. The rate is still high in New York, New Jersey. It's 6.4%, but this region also had the highest rate of decline, down by 1.2 percentage points, led by a 1.6 percentage point decline in New Jersey. And for the 11th consecutive quarter, the rate declined in every region of the country. The rate was down 1.1 percentage point in the Southeast, and that was led by a 2.3 percentage point decline in Florida to a current rate of 4.8%. Based on CoreLogic data, new and existing home sales were up by 7% during the 12 months ending March 2016 compared with a year ago. Sales were up in every region except a 1% decline in the Southwest, and that was partly due to a 15% decline in REO sales. 4 areas grew by more than the national increase, those shown in the darker shade of blue, led for the 3rd consecutive quarter by a 16% increase in the Northwest, where Oregon was up by 21% and sales in Washington were up by 16%. Let's take a closer look at those metro areas in the Northwest region. Traditional resales were up by 20% in the region, with new sales up by 11%. And sales increased in 26 of the 27 metropolitan areas in the region, with the only decline occurring in Anchorage, which is shown in brown. Areas in the 2 lightest shades of blue increased by less than the national average, and areas in the 2 darker shades of blue were up by more than the national average. Sales were up by more than 16% in 14 areas, those shown in the darkest shade of blue. Salem, Oregon led all gains with an increase of 31%. Other metro areas included Portland, up by 21%, Boise had a 16% increase, and Seattle had a 14% increase. Single-family home building, as measured by building permits issued, increased by 12% to 150,100 homes during the first quarter. This was up from a 6% increase last quarter. And permits were up in all regions except the Southwest, where there was no change. The greatest increase occurred in New England, which was up by 33%, with large gains in Rhode Island and Massachusetts. The Midwest was up by 25%, and single-family permits in the Northwest were up by 21%. Looking at the multifamily side, the number of multifamily units permitted declined by 2% to 88,700 units during the first quarter. This compares with a 15% increase last quarter, so a noticeable change there. 5 of the 10 regions had gains, and 5 of the 10 had losses. The number of units permitted was up by more than 30% in the Midwest, the Rocky Mountains, and the Mid-Atlantic region. And the number of units permitted declined by more than 30% in New England and in New York, New Jersey. The New York City metro area had the largest decline in the country, down by 3,450 units, or 38%. This next map shows the change in vacancy rates across the country. For the second consecutive quarter, the national vacancy rate has increased. So this is definitely a noticeable change in the trend of vacancy rates. For a long time, we saw the vacancy rate declining. Now we're starting to see this start to tick back up. It was up by 0.3 percentage points in the first quarter relative to a year ago, compared with an increase of 0.1 percentage points last quarter. According to Reese data, the national vacancy rate was 4.5% during the first quarter, and rates increased in 8 regions. They remained unchanged in the Southeast and declined slightly in the Great Plains. Gains were highest in the Northwest, up by 1.2 percentage points, followed by New England, up 0.6 percentage points. And vacancy rates ranged from 3.4% in New York, New Jersey, to 5.7% in the Southwest. And according to Reese data, which covers 275 market areas, vacancy rates were down in 132 areas, and they were up in 132 areas, and remained unchanged in 11 areas. There were only 4 markets with a decline of 2 percentage points or more, and all of those were in the Southeast region. According to the Census Bureau for the entire U.S., the rental vacancy rate was 7% in the first quarter, down slightly from 7.1% a year ago. Let's take a closer look at the Great Plains region. This was the only region where vacancy rates declined. The regional vacancy rate was 4.1%, down from 4.3% last year. And this map shows the vacancy rates of 14 metropolitan areas relative to the national rate. All areas except for Topeka and Des Moines, which are in blue, are below the national rate. The areas in the darkest shade of brown have rates that are more than 2 percentage points below the national rate, which includes Columbia and Springfield, Missouri, and Ames, Iowa. The vacancy rates in Kansas City and St. Louis are 4% and 4.2%. And what about rents? Rents were up by 4.6% nationally, according to Reese, from a year ago. This is the same increase that we saw last quarter. Rents grew in all regions of the country, again, the whole country shown in blue, and the 4 regions in darker blue increased faster than the national average, led for the 3rd consecutive quarter by the Northwest, which was up by 7.9%. The average market rent in the first quarter for the 275 areas covered by Reese was $1,239. Rents increased in 268 of the metro areas. They were down in 5 and unchanged in 1. 41 areas increased by more than the national average. Let's take a closer look at the New York, New Jersey region, where regional rent growth was also 4.6%, the same as the national rate of growth. Rents in the first quarter were up in all 14 metropolitan areas, shown in blue, and Ithaca and New York City, in the darkest shade of blue, were up by more than the national average, with gains of 8.1% and 5% respectively. The other 12 areas increased at a rate that was below the national increase. And then, in honor of our panel discussion today on child well-being and healthy homes, we've included a couple of bonus maps. In this first map, we show the percentage of children with no health insurance looking at all income levels. For the nation, this average is 6%. The states that are in blue have a rate that's below the national average, and the states in brown have a higher rate. So in this map, it's bad to be in the brown. The darker shades of brown are the states with the highest percent of children without health insurance. And so now, get that map focused in your mind and take a look at the next slide, which is going to show the same thing, except now we're going to focus on those households that are below the national poverty rate and look at this same statistic. Much more brown. So we know that the problem of children without health insurance gets worse as income levels decline. And in this map, we're looking at the percent of children without health insurance for those households below the poverty level. So as you can see, a lot more brown than we had in the previous slide. So in a moment, I'm going to hand this over to the experts, and they can talk about this and several other issues as well. So in summary, year-over-year job growth for the first quarter was 1.9%. Sales markets remained balanced throughout much of the country, with some areas of tightness. Price gains remained relatively stable compared with last quarter, and total sales increased by 7%. Rental conditions remain tight or slightly tight in many markets around the country, and the pace of rent increases remains high, and vacancy rates continue to edge up nationally. For additional information, please go to the U.S. Housing Market Conditions Report on our website, huduser.gov. You can talk with your local regional or field economist, or you can feel free to contact me. So thank you very much. At this point, I'd like to hand things back to Matt, who's going to lead the panel discussion this afternoon.
Thank you, Kevin, for that overview. Before we go to the panel, I just want to give some framing and context. So let's focus on the home. You know, a home is more than just walls or a roof. You know, it's more than just physical space. You know, we have a personal connection with home. It's central to our lives. It's where we create memories, grow, thrive, and celebrate. It unites family and friends. It's a place that's connected to community. But for millions of families and children, their homes pose a threat to their health, safety, and quality of life. Focusing on improving a child's living environment can have a major impact on their overall quality of life. There are about 133 million housing units in America. About 116 million are occupied units. A large portion of them pose a threat to families and children. As of 2013, there were about 5.9 million housing units with moderate or severe physical problems, including pests, mold, water leaks, holes in floors, exposed wiring, and plumbing issues, to name a few. This represents about 5.1% of all occupied housing units. And we know that a child is very susceptible to their living environment and poor housing conditions. One, because they spend a lot of time in home, which may change because of Pokemon Go, but in general, they spend a lot of time in the home. And their absorption of contaminants is higher than adults, 5 times higher in the case of lead. We know from research that housing conditions and health are closely linked, and the associated economic burden resulting from these conditions, is enormous. Home environments are complex, and dealing with poor housing quality is challenging. You know, many of these housing issues are not readily observable, including mold behind walls, radon, a lot of times lead-based paint, and carbon monoxide. Research has shown that the impacts and outcomes on poor housing quality include school absenteeism, poor school performance, long-term health problems, socialization problems, criminal activity, special education needs, costly health care, and many times hospitalization. I wanted to focus on these next 2 slides on the connection of home-based hazards, health, and the economy. This one for asthma. Home-based asthma triggers include pests, cockroaches, mice, dust, trash, carbon monoxide and fuel combustion products, dampness, mold growth, volatile organic compounds, also known as VOCs frequently, home pesticide use, and of course secondhand smoke, and IEQ is indoor air quality. All of these affect 6.8 million children, costing $3.5 billion a year due to dampness alone in the home. In fact, research has shown that about 40% of asthma episodes are triggered by the household presence of mold, dust mites, and rats. Looking at lead poisoning. Home-based lead hazards include chipping, peeling, flaking, caulking paint in homes before 1978. Lead-contaminated soil, lead-contaminated products, household items, pottery, and water. This impacts over 500,000 children, costing billions in medical costs and lost productivity. The good news is that we know from our collective work, including HUD, all of our partners here, our local communities, nonprofits, and philanthropies, we know that this work is a smart investment in our child's future. In fact, for every $1 spent on controlling lead hazards, $17 is returned via improved health outcomes, increased IQ, higher lifetime earnings, increased tax revenue, less spending on special education, and reduced criminal activity. For every $1 spent to reduce asthma triggers in homes, healthcare costs are cut by an average of $10. These problems are complex, but call out for action to prevent the unnecessary injury and illnesses we see in children. Far too many homes don't meet basic healthy homes principles. That is, dry, clean, ventilated, free from pests and contaminants, well-maintained, safe, and temperature-controlled. Poor housing quality is a public health issue that demands research and evaluation, broad partnerships at all levels, education, sustained funding sources, and working across traditional siloed programs. We really need to look at focusing on prevention and looking upstream to prevent downstream problems. And with that rosy outlook, it's now my pleasure to welcome our panelists to the stage. Each panelist will talk about 10 minutes of comments, which we'll strictly enforce, and then we'll move to a moderated discussion. So I welcome all you all to come up, and I would introduce them all as they settle in. And for brevity, I would just include their titles and names, and do an overview right now of their background. Dr. Felicia Rubito is an associate professor in the Department of Epidemiology at Tulane University School of Public Health and Tropical Medicine. Her research interests include residential-based hazards in children's health and focus primarily on respiratory effects of exposure to allergens. Her general area of expertise is environmental and social epidemiology, survey design and methodology, the design of innovative health surveillance programs, and conduct of community-based randomized intervention trials. Her research areas include lead poisoning, pediatric asthma, childhood obesity, exposure assessment, and spatial analysis. Margaret Reed is a registered nurse with a master's in public administration. As the Boston Public Health Commission Director of Healthy Homes and Community Supports, which includes asthma, tobacco, injury prevention, and oral health programs, Ms. Reed oversees program, policy, and regulatory efforts to reduce exposure to tobacco and increase availability of smoke-free environments, and to leverage existing homes to improve housing safety and health, including overseeing Boston Breathe Easy at Home, an online housing code inspection referral system for Boston residents with asthma, and the Boston Asthma Home Visit Collaborative. Next, Dr. Cliff Mitchell is the Director of Environmental Health Bureau at the Maryland Department of Health and Mental Hygiene. The Bureau's responsibilities include food protection, environmental, occupational injury epidemiology, and a wide array of healthy homes programs. He joined DHMH in 2006 after 14 years on the faculty of Johns Hopkins Bloomberg School of Public Health. Dr. Mitchell received a BA from Williams College, an MS from Mass Institute of Technology, an MD degree from Case Western, and his MPH from Johns Hopkins School of Hygiene and Public Health. That's a lot. Dr. Mitchell serves as principal investigator for a number of projects in the department, including climate change, environmental public health tracking, occupational injury and illness surveillance, violent death surveillance, and the department's food protection rapid response team. Randy Jefferson is the housing manager for the Salt Lake County Community Resources and Development. Randy has worked in his current position for 22 years. Salt Lake County received their first lead hazard control grant from the Office of Healthy Homes and Lead-Hazard Control. I know a little bit about them. In 2002, and became a partner in the Green and Healthy Homes Initiative in 2012. Randy's experience in local capacity building and delivering programs that braid and integrate interventions that result from comprehensive partnerships with other organizations such as Weatherization, Habitat for Humanity, and healthcare providers. We will start out with a presentation from Dr. Rubito.
Thank you, Matt. Thank you for the opportunity to speak to you all today. I'm an academic, and so my talk is about where we are with research on interventions to improve the health of children that have asthma. So as Matt mentioned, I guess that's me. Asthma is a serious and highly prevalent respiratory condition. An estimated 6.3 or 6.8 million children, whichever statistics you see, currently have asthma in the United States. Typically, asthma occurs because of a reaction to an allergen that is present in their environment. Not always, but the majority of cases are. And asthma causes a great amount of morbidity in children who have asthma. These include terrible symptoms like shortness of breath, wheezing, coughing. There are economic implications. Children miss school. Caregivers routinely miss work because of caring for their children. And there's a high degree of healthcare utilization, including trips to the emergency department, unscheduled clinic visits, and other healthcare utilization that is unplanned. Something that's important to know about asthma is that there are pronounced health disparities in both the incidence and the prevalence of asthma. But what I'm going to talk about today is children who have asthma and asthma exacerbations, and there are pronounced disparities in asthma outcomes. The reasons for asthma disparities, like most health disparities, are quite complex. But the two drivers are increased exposure to allergy triggers and increased stress in the home environment. We're going to concentrate on the former. I'm going to talk a bit about interventions associated with reducing asthma triggers. The two markers of health disparities are race and income. Low-income children of minority status who live in the inner city are much more likely to suffer adverse outcomes compared to white children. One statistic that stands out is hospitalization rates are 3 times higher among this group of children compared to their peers. The link between housing and the health of asthmatic children is well established and well accepted in the research field. The triggers of concern in the indoor environment, Matt mentioned that we spend 70 to 90% of our time indoors, and up to 2/3 of that time is spent in our home. So triggers in the home are an essential element to controlling asthma. There are numerous indoor allergens. They are biologic and non-biologic. The biologics are cockroach, mouse, cat, dog, moles, dampness. Non-biologics like chemicals, volatile organic compounds, pesticides, and a lot of research in that area right now. Housing that promotes good health is a public health issue, it's a public policy issue, and it's a building challenge. I'm just going to focus on the public health issue since that's my area of expertise. What we're doing in the public health field, in the academic public health field, I should say, is to look at what specific factors are driving asthma triggers. Are all of them equally harmful to children, or are they some that are lead to more pronounced disparities in adverse health? And then secondly, what are the interventions that we can recommend? We know that in the perfect world, we want everybody to live in good housing. There are so many reasons to support that position, and of course we support that. But in the research field, we understand there are limited resources. If there are some things that are greater promoters of ill health, we want to try and identify them. So I always use this as a caution. We know that house dust mites are bad for you. And for years, clinicians recommend to children with asthma, to their parents, that they buy impermeable dust mite covers to cover your bed, your box spring, your mattresses. They're quite expensive. And so I deal with families every day in home visits, and they deal with limited resources. And so they dutifully save money and they purchase these things. But evidence is lacking that how impermeable dust mite covers promote health at all. They do reduce house dust mites, but they haven't been shown to actually improve children's clinical outcomes. So there's a question there between whether we should be recommending these interventions or not, and particularly if you have limited resources. So currently, what we recommend if a child has asthma is a multi-component, multi-trigger intervention that's home-based. What this is a suite of interventions that attack all of the asthma triggers, or most of them that we mentioned. They include education, the use of integrated pest management, filters on your vacuum cleaner and your air conditioner that is a HEPA filter, which is good for particle reduction, and mattress and pillow covers, intensive cleaning, repairs to the home. This is quite difficult intervention to implement. But the pros is that it's evidence-based. We know that if you implement this suite of interventions, children's health improved. They have improved symptoms and reduced need for using healthcare services. The con is that it's difficult to implement, so it's perhaps not feasible for low-income families, and so it's not widely accepted because of its cost. We are interested, our group and others, in determining whether or not all allergens are equal. And what we found is that exposure to cockroaches in the home is particularly associated with adverse health outcomes. Our group has identified that in children with active asthma, those who are exposed to cockroaches are 4 times more likely to be hospitalized compared to children who are not exposed to cockroaches. And these are controlling for all the other variables that they're exposed to. And our group, there are other groups that found the exact same thing. So we're all looking for, like I was mentioning in public health, what are the factors that may be sticking out and something that we can target our intervention on. So we have focused on the role that cockroach plays in asthma exacerbation. Taking the information that I just gave you, along with findings from other research groups that found the similar thing, we designed a study called the No-Roach study, which was funded by HUD, a technical studies program, and we're very grateful for the funding. And it was a randomized controlled trial of 102 children with active asthma. We randomized them to an intervention group or a control group. The intervention was a simple, low-cost, low-toxicity approach to cockroach remediation. It was just the use of insecticidal bait. The use of this bait was based on some work of Dr. Kobe Schall from the North Carolina State University, which showed using it just got rid of cockroaches. So we decided to try it. The goal of the study was twofold. One, we wanted to know if using this insecticidal bait got rid of cockroaches in New Orleans, where I live, where it's hot and it's wet 12 months out of the year. We have a lot of cockroaches. In fact, we say that hurricanes will reduce this city to rubble, except for the cockroaches, which remain. So that was a very important goal of the study. And then the second one was to see if, okay, if we're able to reduce the cockroaches, does it result in improving children's health? Remember what we learned from house dust mites. We were able to remove and lower the house dust, not remove them, but lower the level of house dust mites, but it did not result in clinical benefits for children. It was a 12-month study. We followed the children monthly. The study population was 62% African American, 30% Hispanic. Almost all of the children had income below $25,000 a year. The median number of cockroaches trapped in the home, the little ones, we have the big ones, but we didn't trap those, was about 35. And over half of the children were polysensitized to more than one indoor allergen. We were quite impressed with our results, and in 1 minute, I'm going to tell them to you. First of all, our first goal was to reduce cockroaches, and over the 12-month period of time, cockroaches were eradicated from the intervention homes. At the end of the study, no home had cockroaches. They were completely reduced in approximately 2 months, and they stayed reduced or eradicated over a 12-month period of time. And most importantly is that this reduction in cockroaches resulted in a significant health benefit to the children. We had 1.8 days per 2-week period fewer days with symptoms. That's 47 days a year, fewer days with asthma symptoms. We had a reduction in emergency department visits and a reduction in unscheduled healthcare visits, and lung function was improved in children, significantly improved in children in the intervention group. We're very excited about these results. And in summary, it looked to us like in regions and in homes where cockroaches are prevalent, insecticidal baiting is a simple, low-cost, low-toxicity method to at least eliminate cockroaches. No need for spraying and fogging, which is a lot higher concentration of pesticide in the home and leaves much more pesticide residue. This elimination was achieved and sustained over 12 months. The reduction in cockroaches resulted in a benefit in health, in symptoms, lung function, and healthcare utilization. I would caution you that this is the first study that's ever looked at this research question, so additional studies are definitely needed in larger populations in other regions of the country. But it looks to us, at least from these preliminary findings, that the targeted abatement of cockroaches using insecticidal bait rather than integrated pest management is a promising alternative to multi-component interventions to improve the health of asthmatic children. Thank you.
Good afternoon. Thank you for inviting me here today. I'm Margaret Reed from the Boston Public Health Commission, and I'm just going to be describing Boston, Massachusetts' effort to advance healthy homes in our city. We've had a lot of work going on, intergovernmental and multi-agency around housing, really historically driven by asthma, pediatric asthma around the past 15 years. We're always adding new partners, but some of our foundational partners, I just want to walk through who they are and what they do and why we all bringing our roles together has ended up making some fairly significant changes in housing in our city. Our Boston Inspectional Services Department is tasked with enforcing the state sanitary code for housing in the city of Boston. They conduct over 20,000 housing inspections a year in the city of Boston. We have about 225 units of multifamily rental housing that's not public housing in the city of Boston. So there's a lot of housing that they need to monitor. I'm going to talk later about a couple of their specific things. In about 2013, they implemented a rental registration and inspection ordinance in our city with our city council. So really trying to be more proactive and preventive with their authority. And then they are partner with us and others on the Boston Breathe Easy at Home program, which I'll describe later. Our Boston Housing Authority is our housing, public housing department in the city, and they house about 25,000 individuals directly in their developments, but they administer another 11,000 Section 8 certificates in our city. So because we're a growing city, the number just went down to about 9%, but about 9% of our population is directly touched by Boston Housing Authority. So being able to work with them means we are reaching the 9% of the most vulnerable housed people in our city. Boston Medical Center is our safety net hospital. They helped us to found Breathe Easy at Home. They partner with us on research. They are the home to the Medical Legal Partnership in Boston, so they have brought a critical legal voice to this conversation. When housing conditions particularly around chronic disease, aren't getting resolved and need to go to court, or when a child is not getting the education services they need, maybe because they miss a lot of school from asthma or sickle cell, they advance through their legal work, and they do a lot of policy advocacy. And I do want to say we have two major pediatric hospitals in our city, and the other one is Boston Children's Hospital, and they have been a great partner. They're on our Breathe Easy at Home steering committee, and they are a very aggressive institution, particularly around pediatric asthma. So we're kind of asset-rich in nonprofit resources in the city. And what do we do at the Public Health Commission? Well, one thing, we are tasked with collecting and disseminating health data for the city of Boston. It's a public health function. We did a very smart thing. I wasn't involved in it, but somebody figured it out in 2001. And they started asking, we administer the Boston BRFSS. Our demographic in the city of Boston is very, very different than the state of Massachusetts. So we really need to have our own behavioral risk factor surveillance system. We added a question saying, do you live in Boston Housing Authority housing development? Do you live in a non-BHA development but a rental-assisted housing like Section 8, or do you live in neither? So since 2001, we have been able to stratify our health data by the type of housing people live in. And I can tell you, our housing partners, it gets them to the table. And just a little bit of good news, we are finalizing a manuscript on our Boston behavioral risk factor data that uses the data before 2006, when BHA implemented an integrated pest management policy, and afterwards. And we are finding the association among BHA residents with asthma is weakening. And it's interestingly not happening in our rental-assisted housing, where the health data for those two populations has always mirrored each other. We usually combine the data because the two populations for health purposes are the same. We have done a huge amount of work with our rental-assisted housing, but we don't have one system. So it's not as simple to do smoke-free housing or integrated pest management, because you're working with all these different landlords and housing operators. So that is something we're very excited about. We also do public awareness and public education, and I'm going to close out my presentation, if we have time, with a video that we're doing. We're launching a smoke-free housing public awareness campaign on August 1st. We have a very short video. We do research, and we manage Breathe Easy at Home. So just a quick snapshot about Boston. We're a city that's growing. We are currently a majority people of color city, but we are the most income disparate city in the United States. So the folks that are moving in have a lot of money, and the folks that are being pushed out don't, and are in a large way people of color. We're very lucky in that we have a very active advocacy community, so we can get progressive things pushed through. And healthcare is, other than higher education, our largest industry, so we have been able to do great work with our health institutions. Our city is old, so our housing, including our public housing, is very old. And that makes for a lot of housing problems. Just want to talk, this is a timeline, and a couple of them I'm going to talk about later, but just want to talk about a couple of things. I mentioned earlier, in 2006, Boston Housing Authority integrated a system-wide, portfolio-wide integrated pest management program. We were able to work with them. Some of the outcomes included going to court far less frequently. We actually measured things, getting far less resident complaints, far less relocation requests. But just now we're actually looking at, BRFSS data where we have, adjusted for every other factor, and we're seeing that asthma actually is becoming less associated with living in Boston public housing. In 2010, our then Mayor Menino announced that Boston Housing Authority was going to be the first large public housing authority in the country to go smoke-free, which they did in 2012. So as we collect further BRFSS data, we will be looking at, are there additional improvements over time? I'm going to quickly talk about Breathe Easy at Home. Breathe Easy at Home is a web-based system that allows clinicians to make online referrals for housing code inspections for their patients with asthma in Boston. The inspections are conducted by Boston Inspectional Services Department. The program is managed out of the division that I direct. We have a program coordinator. And it addresses exposures that are covered by the state sanitary code, like mold, cockroaches, rodents, even really damaged carpeting is covered by our code. Clinicians who make the referrals get periodic updates, and really it has some very great side benefits. We started in 2006 and with about 60 referrals, and we get about 250 referrals a year now. It really made it safe for clinicians to ask about housing conditions, because then they could just make an online referral. And the online component of the system was very intentional. Any doctor or nurse could have called ISD anytime, but they wouldn't have spoken to anybody. This really reflects the way clinical practice works, is being able to make the referral while your patient is sitting there. For the inspectors, it really created this environment where it reaffirmed the public health importance of these inspections. I think somewhere along the way, the point of looking for these things in homes had gotten a little lost, but we've been able to provide lots of training and lots of support to these inspectors. They actually tell us sometimes that people they visited call them up 6 months later and say, I just want to let you know, my kid's better. The other point of Breathe Easy at Home is it prevents the dynamic between tenant and landlord. The inspector is very clear, your tenant didn't make this complaint, her doctor did. And the doctor is concerned about this, and you need to be concerned too. And the inspectors have been great. They actually bring information about asthma out now. They talk about smoking, things which aren't in their realm of authority. We have mentored, trained at least 25 other communities. The state of Rhode Island adopted this for the whole state about 5 years ago. We even mentored a province in Canada to adopt a similar system. Another thing that Breathe Easy at Home did was create a very strong advocacy community, foundation, understanding of the relationship between housing conditions and health, where when our Boston Inspectional Services Department in about 2012 or 2013 went to our city council and wanted to amend an existing rental ordinance, the pushback from our real estate community was profound. I mean, I was in hearings where there were twice as many chairs as this, and it was standing room only. And it was serious pushback. But because of this groundwork, there were doctors, nurses, social workers, people with asthma coming out of the woodwork saying, no, we need a preventive system. We don't need to wait until somebody falls, till somebody's porch falls off or till they can't breathe. So the city council did vote to update it, and it was a challenging vote for them. It now means we get preventive inspections every 5 years, more frequently if things are found. It means that every rental property in the city is now registered, and we have about, I think it's like an 85% current rate of registry. And that was an important thing because okay, that's the last slide. And so we have a lot of compliance, and it's a very good preventive public health action. We're launching a smoke-free housing campaign August 1st. These are 4 different types of landlords with 4 different types of properties, and those are their own words, why they went smoke-free. We will have an online toolkit, which I do want to say will have information about how to make your smoke-free policy effective after it's implemented. It won't end on implementation day, because now there's enough of us that have done it that have realized this is kind of hard. And there'll be a lot of social media, and there will be, there's already a video that's out there, and I don't know if we have time for it. No. Okay, thank you. Trying to help you. Oh, maybe it's not me, it's him. Okay.
All right. Thank you very much. And I want to start off by acknowledging the work that HUD and its partners have done in terms of helping the states and the nation think about the relationship between housing and health. I've worked with Matt and Peter Ashley and some of the folks here at HUD for a long time, and it's really been a true collaboration both academically and also in terms of advancing the agenda of health and housing. So with that, let me just start by talking a little bit about the state perspective. I'm from the State Health Department in Maryland, and what I want to do is talk a little bit about how states view the issue of housing and health. As you all know, and as we've talked about, there is a strong relationship between housing and health, and part of the job of the State Health Department is not just to work with the populations through local health departments, through stakeholders at the local level, non-governmental organizations, coalitions that are involved in child protection. But part of our job is to look holistically at the entire range of health issues associated with not only being a child, but that child through the continuum of that child's life. So just to start off with, I do want to say that part of our goal is to think about all the continuum of exposures that occur that Matt talked about, that include not just asthma, which is an acute health hazard that causes both acute and then chronic health problems, but also exposures in the home that can cause lifelong health problems that may not manifest until the child is an adult. So exposures like asbestos and radon, which cause cancer in some cases decades or several decades later, are still very much part of our job and our concern in terms of thinking about the relationship between the physical environment and children's health outcomes. I also want to say that if you look at some of the most important health outcomes for children, they include physical injuries. They include things like falls, electrocutions, smoke inhalation, carbon monoxide poisoning, and these are also associated with the design of and operation and maintenance of the physical environment in the home. So when we think about housing and health, We want to think about that entire continuum of exposures and all the ways in which we can do prevention as part of our activities. And last but not least, and several of my fellow panelists have mentioned this, the relationship between smoking and the home and children's health cannot be overstated. So it's very important for us, and we have a very strong program in most public health departments across the country to try to encourage smoking cessation. So several years ago, the environmental health directors of the state health departments across the country, through an organization, the Association of State and Territorial Health Officials, did a survey of public health departments looking at what kinds of complaints and concerns there were between housing and health in state health departments. And this graph, this pie chart, shows you first where reports about housing conditions and health come from when they come to state health departments. So what we did was surveyed a year's worth of data of reports to state health departments about the kinds of concerns that were raised specifically with respect to physical habitation and health. So as you can see here, 40%, 39% came from private residences. The next chunk came from rental properties, a quarter. And then we also got a number of concerns from other kinds of domiciles or places where children spend a lot of time. So schools, 5%. Even businesses, if you look at indoor air quality complaints, although children were not necessarily the focus here, health departments also get a significant number of complaints related to the physical environment of businesses. So this kind of information then leads to a number of different complaints, and this again is just to show you the range of concerns that the public has about housing and health. And I think one of the important things in terms of thinking about public engagement is that the public clearly appreciates the relationship between housing and health, and that covers a wide variety of programs. By far, the most important or the largest complaint that health departments get related to housing is about sanitation. It dwarfs pretty much everything else, 3 times as high as the next complaint. Now, in our case, there are programs that do a lot of radon work. But we have a large range of other programs from mold, asbestos, lead. Bed bugs are a common concern. And then some less frequently appreciated but also important public health considerations are things like methamphetamine contamination in houses, which needs to be cleaned up, or carbon monoxide complaints. So, if you look at the range of health problems that are reported by people to health departments, you can see the largest chunk there include both asthma and allergies. And I think one of the underappreciated, not by the public sometimes, but by health authorities and others, is that allergies writ large, which includes sinus problems, non-irritant sinusitis, and other kinds of problems, represent a very, very large chunk of what people experience personally as health problems associated with housing. But then you go on to talk about things like cancer and carbon monoxide exposure. These are significant health problems, again, which represent in some ways a very important appreciation by the public of the close relationship between housing and health. And they also represent the kinds of expertise and advocacy that are possible and necessary within health departments and partnerships that are necessary with many of our stakeholders across the states. And so when Margaret was talking about our partners, there are a huge number of partners involved in housing and health, and they aren't necessarily just the ones that you automatically think of. So when we look at improved health outcomes, we need to talk about public health. Healthcare is a very important part of our partnership. Communities, and this can't also be underestimated when you look at the importance of thinking about community engagement. That's the way change happens oftentimes. Non-governmental organizations, schools, and then housing authorities and housing agencies across the country. And one of the things that we've talked about a little bit is the issue of healthcare reform and how that is changing. And I think Margaret and Felicia have both talked about the issues of both financing the kinds of changes that need to occur and incorporating more of those changes in what physicians and healthcare providers see as their scope of practice. So as the Affordable Care Act moves upstream in terms of prevention, it provides an opportunity to focus on those upstream prevention causes, which then can translate into the kinds of curving the healthcare cost down. So moving forward, what are the kinds of challenges, and this is where we just want to spend a little bit of time to reflect on what, from both a state health person and a person very much involved in these issues for a number of years. Human capacity, that is to say, training of community health workers, giving providers more background in terms of environmental health and the relationship between housing and health, and incorporating that both in medical training and continuing medical education. Thinking about the capacity of the surveillance systems to incorporate housing information as part of their ongoing surveillance. So right now we collect in medical records, we collect a lot of information about the health of the individual. We don't collect a lot of information about housing and the physical environment. And so thinking about how to incorporate that in terms of surveillance is a very important challenge, which will require some work. Resources I'm not going to talk about because those are, I think, something that we'll end up on the panel talking about. But the legal and regulatory framework is just something I want to close with. If you look right now at the ability of state and even local health departments to intervene on housing, most of our authority comes from nuisance statutes, which were written in the 1700s and 1800s. They are not really specifically designed to focus on the conditions today and how to think about it. And even things like the International Property Maintenance Code, which many of you in the Housing Authority have much more familiarity with than I do, is a limited tool to be able to address some of these. So I think there's a challenge on the legal and regulatory side to think about. And so finally, something that is a recurring theme here is the disparities that this represents. And so from a public health point of view, addressing the disparities both in terms of focus and in terms of housing will be an opportunity for us to reduce health disparities overall. So I'll stop with that. Thank you very much.
Hi, I'm Randy Jefferson from Salt Lake County and part of Green and Healthy Homes Initiative. Let's see if this is going to work. Oh, there we go. I started with housing rehab probably about 30 years ago. And I have a construction background, and so I actually got hired in a job I had no clue about when they first hired me, and they basically provided about 4 binders this thick and said, these are all the rules you need to follow. And I looked at them and said, this is totally insane. There's no way anybody could ever understand binders of regulations. I would not say that I understand them yet. I just keep a hard copy all the time and call the HUD rep every time I get a question. So I stopped trying to figure it out a long time ago. But the key things that I've learned over the years is in 2000, I had the health department call me up, and I was just about to go to a training concerning CDBG and home and lead. And they had 2 children that were poisoned with lead. And so I told her, let me go to the training and I'll learn about it. Since then, we've been working on it. We've been fortunate now to get our 6th grant for a lead hazard control grant. And we've helped over 1,200 families with their lead program. But we still have a lot to do, and we've got a new grant to work with. And interesting thing that happened recently, there was an article, kind of a follow-up to what happened in Flint, Michigan, and they talked about that in Utah, that there was less than 1% of the children were poisoned with lead. Well, in Salt Lake County, one thing's unique to Utah is we have a lot of children. And we have 110,000 children, about 11% of the population is under the age of 6. And so when the health department kind of pushed back and said it's really not a big problem, and they cited that less than 1% of the children are poisoned with lead, that actually represents 1,100 children. And so from my standpoint, 1,100 children being poisoned with lead is way too many. The other thing that's unique to Utah and Salt Lake County is about 1/3 of all housing units have radon. It's probably the highest, one of the highest levels. And they figure around 3% chance if you have an elevated level with radon that you will develop cancer. And then another thing that we're working on is about asthma, and just very quickly about having 6,000 children in poverty that have asthma. So the biggest challenge we faced is something that probably a number of people have dealt with, and Felicia actually mentioned it about the cost of doing and helping families. And about 10 years ago, we had kind of this unique little moment where somehow all 7 agencies showed up at this home of an elderly woman, and literally every agency had worked on this home multiple times over the last few years. The furnace had been repaired 12 times. There was no coordination between agencies, and so from that, we started, before I knew anything about Green and Healthy Homes, we had 7 agencies come together and just start working together. It was, as anybody knows, getting agencies to work together isn't always easy. And so one meeting I showed up 10 minutes late, and the agencies were just yelling at each other. And I said to them that we give them funding and different things, and so I said, if you don't learn how to work together, I'm going to pull all your funding. Well, nobody believed me, so they called up the mayor and asked him if Randy had the power to pull funding. And he backed me up. He said, he doesn't, but I do. And he told him to start working together. And from this, we actually put together our first collaboration of taking this incredibly bad abandoned home that was in really bad shape, that had sat there for 2 years, worst house in the neighborhood, and made it one of the best. And by doing so, we began to stabilize this neighborhood. And one side effect from this that we didn't anticipate was that the crime went down. Every single idea house we've done since has stabilized and cut crime by almost 1/3, 2/3. So it's real. I wish I could just say everything that's happened over the last few years was all planned out. But basically, I did an internet search 5 years ago and found Ruth Ann and Green and Healthy Homes. And guess what they talked about? They talked about agencies coming together to work together to help families and basically bring resources to help families that normally could not be helped. And so I spent a while to finally get that approved and in place. And then, and again, I wish I could say I planned this out and we just thought this ahead, but through circumstances, ended up meeting a woman named Josette Doris. And we began to help 8 families 2.5 years ago. And we helped those 8 families and did a pilot program where the cost savings within 6 months was $700 per month per family. And it was just amazing how quickly this had an impact on. And so working with the National Green and Healthy Homes Office with White House funding, we began to work together, basically the University of Utah Health Plans and Green and Healthy Homes, to put together a Pay for Success deal. And for the ones that don't, I won't go into all the details about Pay for Success, but it's about social investment, investing in those things that make a difference, that basically builds on what we've done. And we developed what's called the triangle of care, wherein all the things that they've talked about, medication and case management and follow-up and all of those issues have to be addressed. And the best way was through a combination of case management, medical treatment, and the remediation of the homes. And so our goal right now is to, with the new lead grant, thank you HUD very much, and with the Healthy Homes, is to help 800 families over the next 3 years to get rid of asthma, triggers, radon gas, safe and energy efficient. And basically the roots of the problem, to get to those and delete. Shannon gave a great training a while ago at Albuquerque and talked about deficiencies in the home and how those need to be addressed to solve the problem. And from that, we come up with the roots of the solution. And finally, to finish up, I need to tell a story about one of our families. And this was truly one of the neatest stories. And for the ones that picked up the newsletter, the impact of all this is always related back to family and children. And so about 3 years ago, we came in contact with the Fulton family. And if you read the newsletter, it was about a family that bought a house that really wasn't aware of all the issues, moved into it, and all of them became sick, to where a point oftentimes they could not stay in the home. They had flooding of the basement, they had mold everywhere, they had a variety of problems, and to the point where they were just about ready to give up on the home. And then they brought in, we came into it, controlled the flooding of the basement, replaced the carpeting with hardwood flooring, put an air purification unit into it, and it went from the year before we helped them, they had been in the hospital in emergency 110 times, and the year after 10 times. And they called up, and of course she was bawling her head off, and she said, you gave us our lives back. And so all of this really, really does make a difference. And I do really thank HUD for this chance to talk to you.
There, it's green. Now you can hear me. Getting back, I didn't tip Randy off to saying those good things about us on our program, but I appreciate the sentiment. You know, it's a great perspective we all bring to the table. And one, real theme is that I've seen, which has really helped address a lot of the issues, is really a different way of thinking about the housing problems. And, in the past, we've had a lot of programs stood up that have dealt with individual housing issues, whether it was radon or whether it was lead-based paint, whether it was mold. Congress asked us to develop a Healthy Homes program back in '99 where it really looked at individually all of those things. And, we came up with the idea that doing what we could within our infrastructure and framework to look locally at what was going on and how people were addressing housing issues, and making as much as we could our work more flexible so that dollars on the ground really served to benefit in a more comprehensive manner. So again, using our dollars not just on an individual hazard basis, but more looking at a comprehensive basis, which I think certainly has helped orient the word healthy homes, which has been really thrown around a lot, and really the evolution really of looking at the traditional siloed programs and then looking at healthy homes and then going beyond that. And Green Healthy Homes is an example of that, moving beyond that traditional model and adding a core component of weatherization and things of that nature. The one thing I was thinking about is that we have a lot of homes with housing issues. And is it that you're seeing locally more homes? Can you believe this? I this isn't anybody I know, but one time I was at NIH and I was giving a speech, and my wife called and said, "I'm building a fire. Is the damper open?" And I was like, "Well, do you see smoke?" Because it's a yes or no answer. So invariably, somebody always calls me right in the middle of, a speech. But anyway, are you seeing that the housing issues are getting worse, meaning the number of homes are getting worse, or do we just know more about the connection between health and housing, that we understand more about what's going on? So it's more of we have a better understanding rather than we're just seeing a lot more homes being in poor condition.
So I think there are a couple of things there. There are some sort of temporal trends. If you think about building construction type, there clearly are some housing issues which go along with housing type. So take lead, for example. That's clearly a temporal issue in the sense that lead was phased out mostly in 1978, in Baltimore earlier than that. But there are clearly some types of hazards that go along with specific types of housing construction where I think you could actually say there's a temporal relationship. And one example of that would be the whole tight building construction trend that happened in the 1970s around the time of the energy crisis created a whole slew of problems that are now sort of built into that housing stock from that time. So I would say that from a construction point of view, there are some problems that are longitudinal and temporal in the sense that they are related to construction practices over a certain period of time. But there are other problems, I think, that have nothing to do with that. There's a greater appreciation. There are issues that are really much more related to larger environmental, social, and other kinds of problems that I don't think are necessarily associated with anything other than I think we're getting better at understanding the relationship between those things.
I would say part of what's happened having done this for a little while, is understanding of what a healthy home is. You know, with asthma, with radon, 10 years ago, we didn't really talk about it. Radon in the state of Utah, we only started really talking about it about 5 years ago. And when some key actually people died of lung cancer from radon in the home. Asthma, the same thing. I mean, 20, 30 years ago, asthma wasn't that big a problem, and now it's become a bigger problem. So I think some of it is the healthiness of a home, and also I think, get a little spiel on how things have changed over the last 30 years. And we've moved to a more plastic, artificial environment where autism, asthma, and a variety of health issues, which oftentimes can be related to the healthiness of a home, is directly, it's become more awareness and more, people love carpet, for example. And a lot of homes, even some public housing units I've seen, have carpet that's actually really bad and contributing problems. So I think it's a combination of things.
There. I think we're also broadening our thinking about when we talk about healthy homes, what are we talking about? I mean, I think, combining the energy efficiency work with other housing work is critical. In Boston, our Failure to Thrive clinic, in the winter, we have old housing that's poorly insulated and has oil heat. And we have studies going on in our Boston Medical Center that families are forgoing food in order to heat the house in the winter. So, and actually Baltimore is one of those study sites as well. The other thing, and I'm partly saying this because I want to give some credit to HUD, we are finishing a manuscript on a HUD technical study where we looked at the presence of cockroaches, rodents, and mental health systems. And we found an association between cockroaches and depression among the adults, among the mothers. And then when there was rodents in the mix, the association got even stronger. And these are significant relationships. Stress, and these are things that then impact the adult's ability to take care of the child. Like there's a very distinct relationship between maternal stress and pediatric asthma. So, thinking about what do we mean when we mean a healthy house, and what kind of health and whose health, we, need to really be thinking broadly.
So from my perspective, I'm not a housing policymaker, but I've been doing intervention studies in homes for about 20 years. I come from New Orleans, and we have a natural experiment that occurred with Hurricane Katrina. After the condition of the homes prior to Hurricane Katrina was a typical public housing development. They were in very bad shape, very scary, not well maintained, etc. After the storm, HUD rebuilt every housing development in New Orleans, except for one which is being developed now. And the condition of the home and the level of the allergens in it are substantially reduced. We've seen really, really an improvement in the health. It's quite pronounced. What we see in terms of morbidity, though, is that what really seems to be a driver, we've also found a similar situation, is you walk into a home and the home is now physically repaired, which is a huge first start. And the majority of families take that and their children's health has improved, but there are a subset of them that there's just complete disorder in the home. And so it's multifaceted what is a healthy home and what it's going to take for people to thrive, particularly low-income people who are dealing with a child that has a complex health condition like asthma. So the idea of these programs that are rolling in the services and the health care provider, which is not happening in New Orleans. I wrote notes today trying to see if we can do something in Louisiana. We don't have a system where healthcare professionals are rolled in with the housing agencies at all, and it's a disaster happening. You can see it starting over and over again. And the housing has been fixed, the children's health is better. For those people who have a complex condition like asthma, they've got to have access to the health services. So I think, and I'll also say something about HUD, is that I've been doing residential-based housing and children's health in the academic world for a long time. Nobody funded healthy homes except for this group. NIH didn't, CDC, EPA, nobody knew what it was, and that's really a fact. So kudos to forward-thinking
Can we just
researchers
close
in
with
the
that?
agency.
I mean,
It's
I
true,
think
though.
that's excellent.
It's really true.
And it's funny, total sidebar, but we a lot of times struggle with defending, any program struggles with defending it, but it always seems like there's always an additional ask of data of, how are your dollars being used? What is it being used for? Prove the cost benefit and all those different things. And one of the things that we've always wanted to ask a panel like you all is really what additional research would really be helpful in your mind to help provide the information back, as not only as part of a broader outreach strategy, but really as a way to engage people.
Translation of research findings into practice needs to be an emphasis. So I think research into interventions, as I presented today, is absolutely necessary. We don't know enough about the contribution of chemicals to asthma. We think that perhaps VOCs, SVOCs, phthalates may be contributing, but that data is soft at this point. So I think research in that area is needed, but research is not needed in these other areas: dampness, mold, lead, radon, et cetera, and rolling it into health services. So translating interventions into practice, I think, is really where I would like to see the dollars move.
So I spend a lot of time in the surveillance world, and there are a couple of areas where I think we have some missed opportunities, both at the federal level and at state and local level. So I'll just tick off a couple of them. The Family Education Right to Privacy Act makes it very difficult sometimes to collect data on school outcomes and school absenteeism, and it represents, in some cases, a missed opportunity to understand one of the big outcomes that may be associated with a lot of these conditions, which is school attendance and school performance. And so one of the areas where I think there is a need to sort of think broadly about how to improve both research without necessarily spending additional money, but also the research the ability of researchers in the academic world and in the public health world is to think about how to improve our ability to get data on things like attendance and school performance as part of the sort of broader impact on the child, because it also has implications in the child's later development. Another area where there's a real opportunity and a need is that, and I mentioned this before, with the advent of electronic health records and health information exchanges, one of the opportunities, but one that requires some work, is getting not so much the providers, because frankly it's very difficult to get providers to spend additional time doing additional work, but building into the healthcare system, which includes public health, the ability to collect information on longitudinal residents, where people live and where they have lived, and the kinds of information. We do have now more ability to link things like geography with health outcomes. And part of the ability to do that is to take more advantage of the tools that are already out there. So I think collaboration between HUD, the CDC, the National Institutes of Health, and the Environmental Protection Agency, sort of thinking about how to look at this from a systematic point of view. And also, I will say, because I don't have a bone in that fight, to mix a bad metaphor somewhere, is thinking about, from the research point of view, getting the National Institute for Environmental Health Sciences, CDC, EPA, HUD, and others to think about how to provide incentives to researchers to look at those areas would be, I think, an opportunity to spur some of that research.
I think at our health department, what we're thinking more and more and trying to understand is, I mean, when you think about when we all started this work, it was about the structure of the house, right? But people live in the house. And what's the interaction between the humans and their physical environment, and how can we do our work in a to help people to be healthier, not in their physical body and in their sense of well-being. And, you know, what is self-efficacy? Because we've all done the interventions and come back 6 months later and things are falling apart. People have really challenging, complicated lives. They have no money. There's housing instability. So how can we develop strategies to actually help people in their well-being as well as the physical structure, so that they can then maximize the opportunities around being provided the opportunity to maybe have better health? That's pretty abstract. I'm sorry.
I think the one thing, having done housing for a number of years before we started working with the medical community and reading research, and have somebody say, by the way, this really works well, this doesn't work well. We worked with the University of Utah Office of Pediatrics. It was part of the National Children's Study. We're actually working with Brigham Young University, a guy that's spent 4 years studying dust mites. Working with Green and Healthy Homes at a national level because of their work with Johns Hopkins and other issues. And then finally, the most telling and different experience for us and is working with the University of Utah Health Plan nurses and practitioners, that I can tell you, it's a different world. When we can go out and meet with a nurse or a caseworker from the medical world into the home, and then we can combine some of the things that you're mentioning where you do an intervention that doesn't last. I mean, one of the key things in construction that I literally fight for all the time is you want to go into a house once, and you want to do it right, and you want to fix it and deal with deficiencies in a way that it's good for 10 to 20 years. And there's a way to do that, and that's actually combinations. So working with the medical community, to me, is just awesome. And having this connection with all the research and everything, it's a whole new experience for me, one of the best in my life.
Yeah, I think we're seeing that too. I mean, we struggled initially in development our lead house control grant programs is that the health and housing departments really didn't speak to each other because they were in two different worlds. Well, now we're bringing in a third party, which I think is right, the medical providers, and making them part of the conversation and part of the solution, or else we're going to continue the loop of just focusing on patient medication rather than prevention. So we're seeing that as, I think, more and more successes around that, but I don't think that has been really broadly adopted yet. And I'm not really sure how to push that unless, it is based on data, it's based on collaborations, it's based on really those follow-ups that you mentioned after interventions too, Margaret, that, successful strategies are around collaboration. And I know that we've been so focused on getting the house done, right? And I think you're right, though, that post-intervention is something that we hope would continue, and with the maintenance and things of that nature. But I think that engaging with different stakeholders is really critical to look at the continuum, which you talked about, Cliff, really the whole continuum. But what are some successful strategies you've had around building coalitions, all around?
In Utah, I've got 4 ACOs, medical care providers, insurance providers. It took a very unique woman, Josette Dorius, that was their organization isn't as big. They represent about 25% of all asthma patients in Utah. And there's a bigger one, Intermountain Healthcare, and then there's Molina Healthcare. And I can tell you that it took somebody unique like Josette to kind of break down the barriers. We're working with the others kind of piecemeal. And I think that's kind of what happens, whether it's planned out or not. I'm sure across the country they're doing it kind of piecemeal. Here's a doctor really frustrated that here's a really sick child and they've tried everything. And they basically call up pleading with you to go out with them and visit the home. So it isn't structurally out there, it isn't an automatic. There is healthcare systems, and so part of what I'm hoping we accomplish by working on this and even having this type of discussion is for the medical world and the housing world to appreciate the value of when we can go out together and work together on a family.
And there has to be a system for that to work. I was just in awe and complete jealousy of the Boston setup. So if you contrast New Orleans to what's happening in Boston, right? Boston is what you want to be doing with your breathe easy at home, where a healthcare provider can actually make a phone call, which they're more than willing to do, to help their patient. I'm quite sure of that. I've worked enough with individual providers, but if you don't have that system in place, then you can't do it. So there are things that we know, and that's what I mean by translating into practice what it is we already know. So there are certain things that need to be researched, but there are other things that we know. So we know that substandard housing is a contributor to an asthmatic child's health, and so HUD is fixing homes and knows the components that need to be done. But it's more complex than that, and if you want to help health, in particular something like asthma, which is complex, you have to go further. So rolling in the healthcare provider, the people who are on the ground walking into the homes, but you have models that were, even some of which were presented today and in other cities and states. And if there is a way for those of us who don't have it to get some lessons learned and to implement it, but translating what we know into practice, I think is really where we need to be going.
No, I would absolutely agree. But the other hurdle is we have these great models around the country and these great communities of practice, but how do we get it universally adopted? Who takes ownership of this one practice that says this is a really good thing to do? It's a hard thing to build out, the infrastructure and sustainability of this type of work into local governments. And I know that, Baltimore has completely transformed what they've done over the last 10 years in terms of how they've taken and focused on housing in terms of all of their departments and really aligned them under one entity which controls all housing, which I think is unique. But how do we get over that barrier of getting these models of practice, getting this great but not only research, but everything else into sustainable infrastructure and policy? How do we make that, how do we get over that hurdle?
I think some of it will, I kind of almost put things in two different piles. There's what's the population health and public policy dimension that can do a lot for a lot of people through like your city government, through your housing authorities, and then you have your clinical system, and they are seeing the kids that are, and people that are sicker. Just watching the Massachusetts landscape, I feel like a lot of this really taking seriously the social determinants of health are going to fall into place when our accountable care organizations have themselves organized and existing, because then they're going to be paying for it. I don't think they'll, and then, so then I think that they will start to look at their patients more comprehensively, more holistically, start to say, if this kid is, this family is couch surfing, that is not good for their health. What can we do to help stabilize them in housing so that they can be healthy? Or, if this house is in terrible condition, what is our role in improving it? Because it's then going to be, they're going to be paying for it,
So this gets into the nuances of healthcare finance, which is one of my favorite topics to really make an audience just perk up and get really excited. It's pretty much tantamount to just spreading a cloud of poppy dust over the Wizard of Oz and watching everybody fall asleep. But I think, but there are, in line with what Margaret was saying, part of the challenge is the structure of the healthcare finance system, because and I agree with her that when you get healthcare organizations, be they managed care organizations, accountable care organizations, or all the other three-letter acronyms that were created in the other three-letter acronym, the ACA, part of that is that the time horizon for a lot of these is the return on investment really basically has to be within the finance year. And so for some of these problems, we have to actually change the calculus for how people think about investing in prevention versus when they're charged for it. Because I think part of the issue is that for some healthcare organizations, they look at the investment necessary to do a home-based intervention, and they see that coming out in the same calendar year that they're doing the intervention. They don't necessarily see the return for a year or two down the road, and that for them is a problem because they have to recoup the way things work now. They have to recoup that savings in the same year in order for that to make a difference. So I think part of this is the nuance of the evolution of our thinking about the Affordable Care Act and healthcare finance, because I agree absolutely that the long-term solution here is for people to think systematically about prevention and the cost of health and health care. But there is some nuance there.
And I think it's, again, I'm not trying to keep saying good things about that.
Go for it.
As I've worked on the Pay for Success, and we've worked on trying to get Medicaid to pay for things, it hit me a while ago that the LED program, the way it's structured and how we administer it, actually is a good, basically, format. And especially this year when we applied for the grant about the Healthy Homes Funds, and some of the things that you guys put in there actually really help to be able to partner with the Pay for Success. The idea that you're concentrating on outcomes, and from these outcomes, which are very measurable, with working with the medical community, where you have a very sick child, then that child's no longer sick, you can identify those savings. And it isn't just about the Medicaid, but it's foundations or even just local support can buy into this. If I stand up in a meeting and tell some of these stories and also say how much money it's saved, and have next to me a medical provider that's saying, yes, it did this, that becomes a powerful tool. And so I've seen HUD evolve. over the last years, and it's a good direction you guys are going.
ACA, might as well talk about it, Affordable Care Act.
Sure.
I think it's been transformational, to say the least. But from your perspective, how has it been helpful in getting the things done in terms of that, either finding the gaps in funding that you're looking for, or finding sustainable funding, or creating a mixture of different participants and parties that really hadn't come together to work on solutions? I mean, do you see this and the whole thing around healthcare financing as something that really can be used to help sustain this type of work? And again, has it really been helpful to you as of yet, since I think we're still very much in the implementation
So I think
phase?
Margaret may have a perspective on that from Boston and Massachusetts. I would say that the one thing that it's done, and I give, since we're, again, following on Randy's lead, since we're at HUD, I think it should be noted again in a very laudatory fashion that HUD has helped, along with the Department of Health and Human Services and the CDC, to foster a conversation that's going on around a lot of states, having to do with the issue of the Prevention, Reimbursement, Affordable Care Act model that we've been talking about. So the most important thing that it's done, far and away, I would say, is that it's taken some of the demonstration projects that have been done across the country, and it has broadened that conversation. So there are now a lot of states where there's an active discussion going on. They haven't all gotten there yet, wherever there is. Part of that is because the Affordable Care Act itself is obviously evolving over time. Part of it is because we're trying to figure out how this all works together. But the most important thing is that there's clearly a conversation going on in many, many states now about the role that healthcare and public health together play, along with the social and physical environment, in terms of improving population health. CDC has taken up that cause, and there's a lot of conversation that Director Frieden has had about the idea of integrating public health and health care. So, I think that you can go state by state and see that many of those states are involved in a conversation now between the healthcare finance part, the healthcare systems part, and the public health part about how to do this better.
I know Boston has something to say about this.
I guess an example, because I think we're still in our state kind of setting ourselves up to, well, we've had the Affordable Care Act before everybody else had it in Massachusetts, but setting ourselves up for some of the benefits. And one example of really being ready, I think, is an example from our State Department of Public Health. We did get a Medicaid waiver in Massachusetts about 6 years ago to try a pediatric asthma bundle payment to specifically pay for home visits and modest supplies and interventions in the home. So we did receive that waiver, but really healthcare financing is in transition. And I think what happened is I think our Medicaid realized it's not going to be a bundle payment when we're in a position to provide these services. It's going to be paid for differently. So it's not going to be paid for separately from other health care. But meanwhile, what our State Department of Public Health has done so they'll be ready is surveyed all the payers and a lot of clinicians around what would it take for you to pay for asthma home visits and supplies, and what would it take as a clinician for you to refer for those visits? What do you need to trust? So with that information, we actually, the Health Commission with the state DPH we developed under contract with the state a standardized asthma home visitor training that is used statewide. The DPH has developed a standard home visit program, so we're all doing the same thing. And then we have more recently been tasked with now, you know, a community health worker goes to a 4-day asthma training. Asthma is kind of confusing. I mean, particularly if it's going to be a comprehensive intervention where you're going to be reinforcing that person's medical management. You need to know a little bit. So we now mentor all the new asthma home visitors in the field until they are have the knowledge and skills to practice independently. And most recently, we're developing an evaluation tool on those. What are the key knowledge and skills that you need to do to practice safely in the field and effectively around these visits? So with the DPH, we're developing that evaluation tool. So, I mean, we're doing it under contract with them, but it's our state DPH, really great vision, and really, and it's something that, you know, other communities, other states, you know, they'd be happy to share. In fact, the NEAC, the New England Asthma Regional Council, that was the training for their CMMS grant for the home visits, was this training. Yeah.
Are you saying that state Medicaid directors are reaching out to you for information or ideas or data?
I'm bugging them. We're seeking them out. They're not, so far what we've experienced in Utah, they're all receptive to the idea. But they have a myriad, you can imagine, all the complicated issues that are out there. Same thing with the Intermountain Healthcare and other really big organizations. They have a lot of things that they're working on. They have structure and everything like this. And you show up and you say, by the way, I can save you millions of dollars. Well, with some, they jump on board right away. Others, it's just going to take time. And so the one thing that hits me about all of this is the medical community. If I had a vision 10 years from now, I would say across the country 10 years from now, it'll be a common practice, just because there's such a significant cost savings involved in it. And as each, you know, as what you're doing, what everybody's doing comes to focus, then it will happen. And the goal would be to not wait 10 years and have this evolution happen faster. And so I'm not quite sure what role HUD could do in that. I know, like in Utah, we've got a CDC grant for 5 years to fund home visits, and we have the Asthma Coalition trying to get the home visits funded through Medicaid. And so I think it's going to happen, but you know, sooner the better.
So we're coming up on the time for audience questions and answers, as well as anything that's come over on nothing off the oak. Well, audience questions, excluding PD&R staff. Just joking.
I'm Liz
For
Koch.
the panel, not me, for the panel.
I'm Liz Koch with PD&R. And our division works a lot with builders. It was interesting to hear about your builder background. Large number of the issues that you have been discussing are indoor air quality issues that can be dealt with mechanically through better ventilation, and I'd be interested in any discussion about that in terms of best practices and what you have seen work or what you still think we need research on. But also fabric. You also mentioned carpet. Carpet is a big deal. And carpet is a big deal at HUD, and I think we need to look at it more in terms of what FHA allows in an FHA-insured, newly constructed home. But most of what I think each of you are dealing with are lower income, median income households who are renting. And some people find it cheaper to have a, quote, cheap wall-to-wall carpet in the home. Otherwise, they'd have to have a finished floor. And often they don't own a home that has a finished floor. And so you're just constantly going to have, and carpets don't cause the problem, carpets collect the problems. They collect the mites, they collect the dust, and they collect all of the other problems. I'd be interested in hearing from any of you who have dealt with those issues too.
What we're doing in apartments is, again, you have property owners that oftentimes aren't cooperative. You have different things going on. And so we do a real basic, actually we call it a tier 1, is we'll give them a mobile air purifier, we'll give them a vacuum, we'll give them cleaning materials, we'll give them education, and if we can replace even carpet in the child's bedroom and make that a safe environment for that child, that if that child's having a bad day, you can move the mobile air purifier into that room. And the sad thing is you have to get rid of stuffed animals and things like that. But the good construction is about dealing with deficiencies and making sure that the structural nature of the building, and this is hard because in apartments you usually can't do this, but in a home, if there's any kind of significant deficiency, whether it's the furnace, air conditioning, swamp coolers, a variety of things that are actually a contributor, we'll never fix everything in every home. And so our goal is to, one, the education is really important, some degree of behavior modification, and then reducing the asthma triggers in the home the very best you can. And so there isn't a answer, but I can say that, mention like what you said about FHA, public housing actually, in some of the public housing units I've seen, when they do a Section 8 inspection, a unit can pass Section 8 inspection and still leave behind a lot of asthma triggers. And so that would be one thing I would advocate, that overall, whether you're talking FHA, home ownership, public housing, that they need to start factoring in healthy, what the definition of a healthy home is, and come to some kind of agreement on that. So across the board, we just had one family that was just super sick that was in a public housing unit, that they wouldn't replace the carpet because they said, and it was 7 years old and it was bad condition. They literally had just about every asthma trigger again, but they wouldn't do anything because their policy had said, we don't do this until they move out or until this exists and everything like that, even though the whole family was sick.
We just had in our most recent study, residents that are in a new public housing development raise the concern about carpets. They're convinced that the carpets in the home are harboring allergens, which are promoting asthma attacks. They asked to have the carpets removed, and they were told no, that the developer of the facility, they decided that there was going to be carpet. So we met with the Residents' Council and many residents there and told them that because they participated with our HUD grant, again, on asthma, something that they asked us to do was to share the information back in an aggregate form and let them know if there are any data to support the concern that in these units where there's carpet, that there's actually a promotion of asthma and allergic symptoms. So that's our approach. We were not successful in, although I'm not very clever at how to deal with the policy people, since I'm just a scientist, but I do know that data does move policy and definitely gets people listening. So that's what our approach is right now. We're actually just analyzing the data.
Cliff, do you have anything to add? Or?
No, I think that about covers it. I mean, I do think that one of the things that Felicia mentioned is that when we start getting into the weeds, really the weeds of which interventions are the most important, and understanding the relationship between specific children and specific triggers, that's a whole different question than looking across the entire population and trying to figure out what the population impact of, say, global changes in either carpet composition or building practices are. And I really do not know the answer. I mean, I think that it's a really complicated question to know, because with all respect, the carpet can sometimes be the problem itself. There are definitely cases where either mastic or something else, or the carpet fibers themselves, either for some reason that we don't know, will trigger problems in certain kids. So, this is the one where I think there is a difference between a specific carpet in a specific situation with a specific child, and maybe thinking about global policy with respect to carpeting, where I think it's a really complicated question.
Thank you for that question. Any other questions? Hello, Michael.
Yeah, hi, thank you for the great information. I'm Michael Friedberg in the Office of Economic Resilience. So I was at a session a couple of weeks ago with this sort of the term of art, home performance. And there's a whole home performance industry out there that is heavily focused on home performance, but mostly on the energy efficiency side of the house. And there's a great deal of interest on leveraging the healthy housing elements that you're talking about into the home performance, i.e. as an add-on to or integrated with energy efficiency interventions. One of my takeaways from this conversation, and I was only in the latter half, unfortunately, is that this really seems to be the key question, which is operationalizing some of the work that we've been doing and financing, paying for it. So I'm just wondering, one, whether any of you have had any experience on a practical level with bringing these two sides of the equation together, and if not, where do you see the possibilities? Where are the possibilities in this space? Certainly, that's something that we'd be interested in. Matt knows that we have a joint agency priority goal of 150,000 plus energy efficient, healthy housing units every couple of years. And I think to the extent that where we go in and do an energy intervention, it would make sense, particularly in public housing, in lower income housing, the Section 8 voucher program, portfolio, et cetera. Where we're going in with energy interventions, it would make sense to, I think it would make sense. I'd be interested in your perspective on this.
Well, I've worked on energy efficiency. Actually, we got an EECVG grant a few years ago, and we did 80 homes, and that got us some degree of understanding of energy, like I mentioned our idea houses about energy. To me, the key issue is just the concept of a healthy home. That homes, no matter who you are, there's certain things that you just shouldn't have in a home. And there's common practices about carpet that, just like you said, it would be really hard to cross the country to convince everybody to at least give up part of their carpet. There's air quality, there's so many, this is what I've learned is there's so many significant issues in a home. One study that showed was that in Salt Lake, Utah, we have some of the worst air during the winters, just absolutely terrible. And the one professor came back recently and said, our air quality in homes is 2 to 3 times worse than the worst air outside. So there is, personally, as I'm working with the homeless issue, public housing, different housing issues, this idea of a healthy home with energy efficiency just actually is good construction, good building. And that idea of what a good housing unit looks like is actually one thing this is relatively new. This is not, we haven't worked on this for many years. We've done all these things. We've literally spent hundreds of thousands, millions of dollars over the years on fixing homes. But this science of a healthy home is where we need Felicia and everybody around this table and this type of discussion to work towards making people more aware of what things in a home make a difference.
So my perspective on this is that energy efficiency is rolled into also green housing, the idea of green housing and healthy housing. So there's been a lot of discussions over the last 10 years about the definition of healthy housing and where is the intersection between green housing, energy efficiency, and healthy housing. So energy efficiency, the question there is whether you tighten up the home to such an extent that you're actually increasing the concentration of the contaminants in the home. And that's pretty much, I think everyone understands a concern. It's a building practice issue. My understanding is that the building associations understand that, and the ventilation systems have to be installed in such a way that you don't tighten up the home. Then there's the greenhousing, and the problem with greenhousing, the question is whether greenhousing is healthy housing. So you might like greenhousing just from an environmental perspective, which is a fair position, but the intersection of greenhousing and healthy housing has not been proven yet. So there's a large research study currently ongoing. But the problem there is the definition of greenhousing. So the definition of greenhousing is an inconsistent definition. So some housing is greenhousing because they use energy efficiency. Some is greenhousing because they use IPM, energy efficiency, plus low VOC carpets, but then they're using paints that have VOC, glues that have VOCs. Then you roll in personal care products, pesticides, et cetera. So it's a fairly complex, I think, question. But certainly energy efficiency and healthy housing, that to me personally, the link that I've seen over the years is moisture. So if you can tighten up a home to a degree that you're not increasing the dampness, but you're decreasing the dampness and the mold, you're clear on healthy housing to a great degree, if you get the low-hanging fruit, because moisture promotes mold, house dust mites, cockroach, and dampness itself, in the IOM report years ago now, is directly causally related to asthma development and exacerbation. So I think there's a very strong relationship, and to the extent that you can reduce the moisture in the home, you'll be developing a healthy home through energy efficiency.
Cliff, you look like you want to say something.
So I've spent a lot of time dealing with this question, and as I said, I mean, you think back to 1970 and the energy crisis, and the result of that whole discussion was exactly what sort of gave us our first impression that maybe a tight building was not necessarily a good building in all cases. So I agree absolutely with everything that's been said here. The one thing I would say is, at the end of the day, I think we have to use data for this. And I don't think that necessarily, I think that the idea of designing ventilation systems, and thinking about building integrity, what goes into the building, what products are in the building, all of that, I suspect we are still at a point where we don't necessarily understand all of those relationships completely. And if you think about, there's a whole school of thought around the development of asthma, which among other things would say that, you don't want necessarily kids, especially in very, very early life, to necessarily have a really, really sterile environment, because that might actually increase their chances of developing asthma. Which has to do with farms and a whole bunch of other epidemiology. Exactly. So I think that in general, I would say that if we do we look at performance thoughtfully, and we think about it holistically, not just from the point of view of the operation of the house, but its impact on the occupants. Things like operation and maintenance, which actually drive me completely wiggy, because I've seen some wonderfully built systems with wonderful electronic controllers that the occupants couldn't deal with at all, and that therefore, as soon as the builders left, things went to heck in a handbasket, I should say, because the occupants didn't know how to deal with a high-performance building. And we actually saw that a lot in some really advanced schools, which were high-performance schools. I was on an IOM committee looking at so-called high-performance schools and school performance. And the same thing was, exactly the same issue came up, that unless you're dealing with the specific definition, as Felicia said, of exactly what you mean by a high-performance building, I'm going to challenge you I'm not going to be able to tell you whether it's a good idea or a bad idea from a health point of view.
I think we can agree that designing buildings that are energy efficient and reducing moisture is pretty much a mandatory low-hanging fruit kind of, there's no downside to that, because it does promote the growth of allergens. We're sure of that. That is what the research does show.
Correct.
And the research does show that promotes the development and the exacerbation of asthma. And I don't think we have to worry about the hygiene hypothesis on that one, because it's not a sterile environment.
Correct.
So.
I would agree with what both said, because the kind dry climates. And so that's what I'm talking when I'm talking about. There's some really basic elements that we already know that really help, and that's the moisture issue and energy efficiency, because no matter where you live, there's some type of energy issue. You know, we have really cold winters, and so we need insulation in our attics. We need tighter homes, but we also need to have a good ventilation system installed, and the science is getting better. Just as we're talking, they're coming up with better air purifiers and different things. So,
The one other thing I would add to that is, you know, when I look at a building, I tend to think of it as an organism. You know, in some sense, a building is like a biological system. The most resilient biological systems are not the ones where they're designed to build and never fail. That's not how the human body works at all. The human body is, in fact, designed to fail, but it has immune surveillance and other systems that are in place to correct failures. And one of the things that I think, you know, in my own sort of philosophy of building science, I think that if you look at a building as a mechanism and then think about how to design a performance building, is one that will have continuous failure and identify that failure and self-correct. That, for some reason, that in my mind is a more resilient, high-performing building in some respects than a building where you design it as a box that you think is an impervious, never going to fail box.
And also, you know, from our perspective, you know, a house is it has to be in balance. And you know when things are out of balance because you'll see things like mold. And when we were working on our healthy housing principles, we had ventilation in there, but we added an eighth one, which is temperature control. Because too hot or too cold or the opposite is not conducive to a healthy environment. But, you know, in terms of thermal control and energy performance, we replace windows, not because of that it's energy efficient. We replace windows because it's a major source of lead hazards. So in many ways, we kind of get to the point without saying that it's energy performance, but in many ways it's addressing lead hazards. But then also in weatherization and plugging up holes, well, that also stops bugs from coming in the house too as well. So in many ways, we may come to the same conclusion, but in different ways of saying it and working it through our programs. But that's how we're trying to build in this infrastructure is again, looking at a house as a balance. And then, again, many times we get a lot of the energy savings just because of the work that we do from replacing windows or plugging holes and things of that nature. Again, trying to get the house in balance. Thank you, Michael. Another question?
Thank you. Just a quick, I appreciate the discussion. There's sort of two sides of this equation, it seems. There's no question that we are building houses tighter as we're doing more stringent, more current energy codes. We're now down, I think, to 3 air changes an hour at 50 pascals pressure. That's down from 7 in the 2006 IECC code. We had the passive house folks come in here a few weeks ago. They're at a half an air change per hour. I mean, that's super tight. So the whole question, as Liz was saying, of, you know, ventilation and figuring out how these buildings breathe appropriately is really key. So there's sort of a defensive, proper, good practice thing that we really have to focus on. But the second thing, which hopefully we can explore further, is how we sort of leverage the opportunity where you have an energy specialist in a house. If they're also trained as a health specialist, can you get 2 for 1, as it were, and vice versa? I think that's sort of the thing that I'd be interested in going forward as perhaps a follow-up discussion.
Right in here and respond to that, and it's in agreement with what Matt just said. Energy efficiency, I'm assuming that you tighten up the home in terms of cracks, holes, and things like that. That's where the pests come in. So mice, actually the two leading, we think that morbidity is being driven by especially health disparities, that population, by cockroaches and mice and rats. And so if in an energy efficient rehab, I'm assuming that you have to fix those cracks and all of that, you definitely get a health benefit, and there's no downside. That's just an excellent marriage of those two things.
So I've been kind of talking about all the wonderful things happening in Boston, and I've kept my mouth shut on this conversation because I think in terms of new construction and rehabilitation of our affordable and public house, we're doing well about thinking about health and energy at the same time. One place where the office I direct and our energy office are very committed, but we haven't figured out how to operationalize it, is our energy office is doing an amazing job of working in essentially our triple deckers, new heating systems, insulation, solar panels, and they're so impressive. They have community outreach workers that door knock in specific neighborhoods and try to, we can do this for free. So we know we need to work together, and we want to work together. We just haven't figured it out. It's like they're busy with their mission, and we're busy with our mission, and we have to we share information. We give their stuff out, they give our stuff out, but integration, we're not there yet.
Let me just point one thing out, bring up Shannon again. She gave a training in New Mexico on modifying the HHRS rating system, correct me if I'm wrong here, Shannon, where you make adjustments so that you go through for the ones that don't know, it's a Healthy Homes rating system, actually came out of England, and it does some certain things where it identifies life-threatening things, but other things like asthma, energy efficiency related to healthy homes, you actually have to modify it and put in priorities. So there's a way to do an assessment in the home that actually modifies it to prioritize taking care of all of the issues. And to me, I thought it was a great idea.
So I was intrigued by your thought, because one of the things actually, and I will say to our credit, our Department of Housing and Community Development came to us and asked whether or not we could help them with an evaluation of the health impacts of their weatherization program. And so that it's a very nice opportunity to actually think about exactly that question. And we're actually designing and putting together a study, an evaluation to look at what the health impacts would be, and I'm going to be careful to say health impacts, not health benefits, because we're going to look at both sides. We're basically going to look at a range of endpoints, including asthma, lead, and other things that they can do as part of their weatherization program. But I think, this is, again, a question of figuring out ways to engage with the housing community. I want to give credit to and this is our State Department of Housing and Community Development actually came to the Public Health Agency and said, we think that it would be a valuable thing to actually look at what the health impacts are and then figure out ways that we can actually then talk about that as we talk about weatherization more generally. So I think that there's some interest, and it's not just coming from us, it's also coming from our housing folks.
Let me just point out one to support what he just said is the evaluations. One of the challenges, this is not negative of HUD, but one of the challenges of dealing with HUD is 99% about compliance. And evaluation isn't inherently part of it. You have your requirements that you absolutely have to meet, but to do an evaluation, like you just said, is actually a key part of the Pay for Six Medicaid, evaluating what we're doing in the home, whether or not we have the impact and the outcomes. And so to improve outcomes, we've got to actually build within HUD's funding and programs more of evaluations. You guys encourage it. I'm not saying you haven't done that, but there isn't, having worked with HUD for all these years, it isn't automatic. I had a home program monitoring visit last year, and they got all through, checked off the list and said, yeah, you're in compliance with these things, you didn't do this right, and you need to fix this. And then I'd try to bring up some of the things we'd accomplished, and they'd say, well, that's nice. And so we really have to have that evaluation and tying into the medical and the research and things like that. That's where we can actually begin to make some changes.
Thank you. I think we have time for one final question. Yes.
I'm Lydia Tagavi from PDNR. There is no mention of the role of the public education sector. We are looking for data. There are, I guess, opportunities for collecting data through the public education, public schools, health and public school data and housing. I have not seen any of this information together, but this is again, I probably is stepping into some privacy information, big time. But these are information because Dr. Mitchell mentioned about human capacity and engaging the community. I am the community. And I need to be engaged. I need to learn what's wrong with my house, how to use the affordable healthcare system. I have an insurance with HUD right now, with health insurance. But when my son turned 26, I have to help him navigate this website that became really a nightmare for us. So I am the community.
Thanks, Lydia.
So I will not speak for my fellow panelists here, but I bet they have the same experience I have, which is it's very difficult. I couldn't agree with you more. We have felt very strongly and been really interested in issues related to things like school attendance, school performance, the engaging with school systems, and particularly when you talk about trying to collect evaluation measures, anything having to do with schools ends up, much of it, falling under the Family Education Right to Privacy Act. And it's basically, you can think of it, although it's not really that, as HIPAA for schools, but it's actually much stricter. It really does make it very difficult to collect individual school-level data on kids with any kind of condition, because anything that's considered their that's considered their educational record, which is basically everything that happens to them in and around the school, you can sometimes, and some of us have had some success in some cases, getting aggregate data out of the school, but individual level data of the kind that we'd want to be able to do this kind of work is very difficult to get. So I couldn't agree with you more about that, but there is a constraint in terms of being able to do that, which is different than with the other part that I thought you were talking about, which is engaging with schools about opportunities for outreach, talking with communities, et cetera, where I think there are real opportunities. But at least in terms of the evaluation part, it's really difficult to do.
Any other comments from the panelists?
We've engaged with school health nurses in order to try to do the former, to identify children who are uncontrolled asthmatics and to provide services. We wanted to get them into research studies, but to hook them up with the healthcare services. School nurses were routinely very, very interested, but with budget cuts, most of the schools don't have full-time school nurses. Many of them just didn't get the support of their administration. That's been my experience in our community. But I think it's a very rich source for both outreach and for education of both parents and children for asthma management as well as navigating the healthcare system. We just were not successful in doing it. They didn't have the time in the day.
Yeah, I would say our experience, we work very closely with our school system. We've had a city ordinance that requires every school be inspected every year by inspectors from the Health Commission, and the report has to be publicly posted on the school's website. The office I direct is actually supporting the time of 4 nurse asthma leaders at our schools. And when they have the capacity, they provide really interesting aggregated data around, they really have been able to look at which schools have the most absenteeism related to asthma, the most absenteeism in general. But As a system, at least my experience with a large urban school district, it's a really stressed system. And their ability to respond to these things is really hard. They also find, because they are where the kids are, that everybody wants to work with them on everything, every research project, and I think it can be hard for them.
Thank you for the question. One last quick question or wrap up? Anything anybody submitted on Twitter or anything else, or submitted via email? Nothing has come in? No? No? Okay. Well, with that, it's a great pleasure to have you all here. You know I'm a super fan of all your work. Been for a very long time, so it's great that we've all come and talked about this in a forum, health within a Department of Housing. I hope that's not a unique thing. I hope it's a long-standing thing, and we touch so many lives and so many families and children that I'm glad that it has really risen as an integral part and a social determinant of health. I think that's great. Thank you all for being here on a very hot day, and I wanted to remind you that our next quarterly briefing is in October on housing finance challenges. So with that, I'll close with a big thank you to the panel and a thank you all for joining us today.